I want you to look at your medicine cabinet tonight, count the bottles. Now ask yourself one honest question. Do you actually know what each of those pills is doing inside your body after 60? Not what the label says, what it is actually doing. To your kidneys, to your brain, to your arteries, to the nutrients your heart depends on every single day. Because here is the truth nobody told you at that appointment. Your body at 65 is not the same system it was at 40. It metabolizes medications more slowly, it depletes critical nutrients faster, and it has far less reserve when something starts going wrong quietly in the background. The clinical guidelines driving most prescribing decisions were built from research on younger, often healthier populations. Not you, not your body, not your specific biology right now. I'm not telling you to stop your medications. I want that on record from sentence 1. This is about the mechanism your doctor didn't have time to explain. The nutrient depletion nobody warned you about. The conversation you deserved to have but didn't. I'm Dr. Danzy, and today I'm walking you through 5 pills I would never take after 60 and exactly what I would do instead. Stay until the end. Because the 5th one is the one that concerns me most, and it is the one sitting on the nightstands of millions of Americans right now. Pill number 1, calcium supplements, not the calcium in your food, the tablets, the chews, the 600 milligram caplets marketed to women over 50 for bone protection. Here is the mechanism nobody explained. When calcium arrives from food, it comes packaged with vitamin K2, magnesium, and trace minerals that act as routing instructions. Those instructions direct calcium into your bones and away from your artery walls. The food does that automatically. A calcium tablet has no routing instructions. It floods your bloodstream with calcium and without K2 acting as the address label. That calcium deposits in the nearest available surface, the lining of your arteries. Over years, this contributes to arterial hardening, elevated blood pressure, and increased cardiac risk. A BMJ analysis of nearly 24,000 participants confirmed this. Isolated calcium supplementation is associated with elevated risk of arterial calcification and cardiovascular events in people over 60. The supplement prescribed to protect your bones may be quietly hardening your arteries at the same time. What I would do instead: get calcium from food. Sardines with the bones, cooked kale, full-fat yogurt, sesame seeds. If supplementation is truly necessary, it must be paired with vitamin K2 in the MK7 form, 100 to 200 micrograms daily, plus magnesium, never calcium alone. The routing instructions matter as much as the calcium itself. Pill number 2, proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, Prilosec, Nexium, Protonix, designed for 8 to 12 weeks of use, but for millions of Americans, short-term became indefinite, years, sometimes a decade or more. Here is what is happening inside your body during that time. Stomach acid is not the enemy. It is how your body extracts vitamin B12 from food, how you absorb iron and zinc, how you kill harmful bacteria entering through your mouth every day. Suppress it aggressively for years, and those systems fail silently. Research published in JAMA found long-term PPI use is strongly associated with vitamin B12 deficiency. And B12 deficiency after 60 is not just fatigue. It causes numbness in the hands and feet, balance problems, word-finding difficulty, cognitive fog that gets misdiagnosed as normal aging or early dementia. And here is the part that makes it worse, specifically after 60. Stomach acid naturally declines with age. You are already producing less at 70 than you did at 45. Layering a powerful acid-suppressing drug on top of an already declining system drives your nutrient absorption into a state it was never designed to sustain. What I would do instead: address the actual cause. Reflux is almost never too much acid. It is a failing esophageal valve, triggered by large evening meals, lying down after eating, alcohol, and carbonated drinks. Fix those first. For additional support, DGL licorice soothes the esophageal lining without touching acid production. If you are currently on a PPI, do not stop abruptly. Rebound acid hypersecretion is real and uncomfortable. Ask your prescriber about a supervised taper, and at your next blood draw, request a B12 level and a magnesium level. These are the first two casualties of long-term PPI use, and they are almost never monitored. Pill number 3, statins for people with no prior cardiac event. Let me be precise here. For people who have already had a heart attack, a stroke, or a coronary stent, statin evidence is substantial. I am not addressing that group. I am addressing the large and growing population placed on statins for elevated cholesterol numbers alone, with no prior cardiac event. In that group, the risk-benefit calculation after 60 is far more nuanced than the prescription implies. Here is the mechanism nobody mentions. Statins work by blocking an enzyme in the liver that produces cholesterol. That same enzyme also produces CoQ10, coenzyme Q10, the molecule that sits inside the mitochondria of every cell in your body and powers cellular energy production. Your heart muscle contracts 100,000 times every single day. It depends on CoQ10 more than almost any other tissue in your body. Every statin user is simultaneously depleting their own CoQ10 production. The result is not subtle: persistent muscle aches, crushing fatigue, exercise intolerance. Symptoms that are consistently dismissed as simply getting older. After 60, mitochondrial function is already naturally declining. Statin-induced CoQ10 depletion accelerates that decline at precisely the age when you have the least reserve to absorb it. What I would do instead: if you are on a statin, add ubiquinol CoQ10. That is the reduced, directly usable form. 100 to 200 milligrams daily with a fat-containing meal, because CoQ10 requires dietary fat for absorption. This does not undermine the medication. It corrects a documented depletion the medication creates. Also ask your prescriber one question that almost never gets asked. Has my 10-year cardiovascular risk score been recalculated recently? Because that number changes as you age. The calculation that justified starting the medication may look very different today than it did 5 years ago. Pill number 4, regular NSAIDs, ibuprofen, naproxen. These are available without a prescription, which creates a false sense of safety. The pharmacology does not support that safety after 60. Here is what is happening inside your kidneys. Kidney filtration rate declines by approximately 1% per year after age 40. By the time you are 65, your kidneys are already operating with significantly reduced reserve. NSAIDs constrict the blood vessels that supply the kidneys. In a younger person with full renal reserve, that constriction is temporary and tolerable. In a person whose kidneys are already working at reduced capacity, chronic NSAID use accelerates kidney function decline in a way that produces zero symptoms until the damage is significant. There is no pain in early kidney decline. It is completely silent. The first sign is often a lab result nobody ordered because nobody thought to look. The second mechanism, the protective mucus lining of your stomach and intestine, becomes thinner after 60. NSAIDs work by suppressing the compounds that maintain that lining. Regular use, even 2 or 3 times per week, carries substantially elevated risk of gastrointestinal bleeding in adults over 65. This is a documented, preventable pattern showing up in emergency rooms across the country. What I would do instead: topical diclofenac gel applied directly to the painful joint delivers meaningful local pain relief with a fraction of the systemic exposure. Omega-3 fatty acids, 2 to 3 grams of combined EPA and DHA daily from quality fish oil, reduce the inflammatory signaling driving joint pain at the source. And magnesium, deficient in the majority of adults over 60, directly regulates the inflammatory pathways involved in chronic pain. Ask your doctor to check your current kidney function with a GFR measurement, especially if you have been using NSAIDs regularly for months or years. Pill number 5, sleep medications, benzodiazepines and Z drugs, Xanax, Valium, Ambien, Lunesta. This is the one I want you to pay closest attention to. In 2023, the American Geriatric Society updated its official list of medications considered high risk in older adults. Benzodiazepines and Z drugs appear prominently on that list, not because they fail to produce sedation. because in adults over 65, the accumulated risks have become impossible to ignore. Here is the mechanism. These medications enhance GABA activity in the brain. They sedate you. They produce the feeling of having slept, but they do not produce the architecture of restorative sleep. Specifically, they suppress slow-wave deep sleep, the phase during which your brain's glymphatic system activates and clears metabolic waste, including the amyloid proteins most associated with Alzheimer's disease. You feel sedated, you wake feeling unrefreshed, and the critical brain cleaning process that only deep sleep can perform simply does not happen. Research published in the BMJ followed thousands of older adults and found a significant independent association between long-term benzodiazepine use and elevated risk of Alzheimer's-type dementia. This finding has been replicated across multiple independent populations in multiple countries over more than a decade of follow-up. And the second mechanism, these medications affect balance, reaction time, and coordination. Falls are the leading cause of traumatic injury and injury-related death in adults over 65. A medication that sedates you through the night and then impairs your coordination when you get up at 2 a.m. to use the bathroom is a documented, measurable fall hazard. Every emergency physician knows this. Almost no prescribing physician communicates it. What I would do instead: address the actual root cause of the sleep disruption. In most adults over 60, poor sleep is driven by suppressed melatonin from evening light exposure, elevated nighttime cortisol, undiagnosed sleep apnea, or fluid redistribution from leg swelling that forces repeated bathroom trips at night. For melatonin support, 2 tablespoons of tart cherry juice concentrate in warm water 90 minutes before bed. Tart cherries are one of the richest natural food sources of melatonin precursors. Clinical trials have shown consistent improvement in sleep onset and duration. Magnesium glycinate, 300 to 400 milligrams taken 60 minutes before bed, supports natural GABA activity and promotes deep sleep without suppressing sleep architecture. And the 4-7-8 breathing technique. Inhale through your nose for 4 counts. Hold gently for 7. Exhale completely through your mouth for 8. This activates the vagus nerve and measurably reduces circulating cortisol within minutes. 4 cycles every night before sleep. Start tonight. If you are currently on a benzodiazepine or a Z drug, do not stop abruptly. Withdrawal must be managed gradually under supervision. What I am asking you to do is have one honest conversation with your prescriber. Is this medication still serving the purpose it was prescribed for? And is a supervised tapering protocol with alternatives introduced alongside it something worth exploring? One man I want to tell you about was 69 years old. He was on 4 of these 5 medications simultaneously: a statin, a proton pump inhibitor, a calcium supplement, and a sleep medication. He came in exhausted. His legs ached constantly. He kept losing words mid-sentence and it frightened him. His standard labs looked fine. That word, fine. But when someone looked deeper, B12 critically depleted from years of PPI use. Magnesium at the absolute floor of the reference range. CoQ10 significantly deficient from the statin. And his sleep medication suppressing the deep sleep phase that would have been clearing the metabolic waste accumulating in his brain every single night. None of those depletions had ever been monitored. None of them had ever been connected to the medications he had been taking faithfully every morning because a doctor told him to. 6 months later, CoQ10 added, B12 supplementation started, magnesium glycinate before bed, a supervised taper off the sleep medication with alternatives in place. He said it was the first time in 3 years he felt like his mind was actually working again. Not a miracle. A mechanism identified and corrected. Here is what I want you to do before your next appointment. Write these 6 lab tests down and ask for them by name: vitamin B12, serum magnesium, CoQ10 if you are on a statin, fasting insulin, vitamin D, and ferritin. These are the numbers that reveal how your body is actually functioning underneath the surface. Most of them will not appear on a standard annual panel unless you specifically request them. Your body after 60 is not the same pharmacological landscape as your body at 40. The medications prescribed under one set of assumptions need to be reevaluated as those assumptions change. That reevaluation is your right as a patient, and it begins with knowing exactly what questions to ask. Now I want to hear from you. Drop your age in the comments right now. Tell me where you are watching from. And tell me this, how many of these 5 medications are you currently taking? Have you ever had any of these 6 lab tests ordered? I read every single comment, every one. If someone you love is taking any of these 5 medications without understanding what they are doing inside their body after 60, send them this video. They deserve this information. They are almost certainly not receiving it at their appointments. I'm Dr. Danzy. Subscribe to Dr. Danzy Senior Health Tips, and I'll see you in the next one.